Okay, finally, in this session, welcome Toon van Gorp, who I'm sure will have trouble with his slides because everyone else has. Oh, I'm not sure, but we'll see. We've asked Toon the enviable task to talk about new tumour markers and proteomics. I should say that Toon is a proper gynae-oncologist from Maastricht, but has had very close links with Leuven, and I think did your PhD here, didn't you, Toon, I think? Did you do your PhD in Leuven or not?
Yes.
You did, okay. So, and I think you will mention over one, so I'll look forward to hearing from you.
Thank you. Like he said, I'm Toon van Gorp. I did my research on proteomics and ovarian cancer. I have no disclosures, but the only disclosure that I have is that my voice is giving up. So I hope I make it until the end of the session. Like always, I'm going to start with the take-home messages. And the first question is, are there any new markers based on proteomics for ovarian cancer? And the answer is yes, lots of them. There are lots of possible markers. But the next question, and probably the most important question that you have to ask is, are there any new useful markers based on proteomics for ovarian cancer? And there the answer will be no. I suspect that there are a lot of clinicians in the room, so I'm going to just basically explain what proteomics is. It looks very simple. I'm going to explain you the most simple technique. There are lots of techniques and more complex techniques, but this is the one that came into the picture in 2002, and I will be talking about that soon. But what we do is we put a sample, a serum sample or a plasma sample or a tissue sample on a metal plate. We shoot on it with a laser. The proteins in the sample get excited and they get a positive charge. And when you apply a high power field across a tube, then the proteins, the positively charged proteins will start flying towards the detector. And what you see is that the small proteins will fly faster than the big proteins. And they arrive first at the detector. And you will see a spike arriving. And then the bigger proteins will come. And finally, the biggest proteins. And the amplitude of the spike is, of course, the amount of proteins which is with that particular mass. So in the end, you get a spectrum like this. And what you see is you have two spectra. One is of a cancer patient, and the other one is of a patient who hasn't got cancer. And you try to look for the differences between both spectra. And this is very obvious, of course. There's a very big peak in the cancer patient, and there's almost no peak in the patient who doesn't have cancer. This is the basic principle, and it looks very simple. The problem is that when you generate a spectrum like this, you get millions of peaks, because you have millions of proteins. And this is a very big peak, but you also have these very tiny peaks. And most studies only used, well, up to maybe 100 or 200 patients, if you're lucky. Some studies only used, for example, 20 patients. So in 20 patients, you try to look at difference. You try to look for a difference in, lots of peaks, too many peaks actually. So this is statistically, this is a very big challenge. Like I said, the story started in 2002. Proteomics has been developed in the previous century, but it came to the eye of the clinician in 2002 when this pivotal paper was published in The Lancet by Petrocoin. And it was actually the first clinical paper on proteomics. It was on ovarian cancer. And they discovered a set of peaks. They didn't even analyze the proteins behind the peaks. And this set of peaks was able to discover ovarian cancer with a sensitivity of 100% and a specificity of 95%. This is very high. This is much higher than CA125. And they very quickly went for patent filing, and they tried to make a test out of it. They even filed it to the FDA to get approval, but they didn't get it. And this is because there was a lot of there was a lot of criticism on how the study was performed, and the data of the study was reanalyzed several times afterwards, and several mistakes were found in the setup of the experiment. Since the Lancet paper, more than 400 papers have been published on ovarian cancer and proteomics, and only few biomarkers have passed validation. And when they pass validation, the performance of the markers is, of course, much less than in the discovery studies. Why is that? I'm not telling you any secret. It has been told before in this today in this symposium. Ovarian cancer and benign ovarian cysts are very heterogeneous. So it's very difficult to find 1 or 2 or 3 markers that fits all kinds of cancer and fits all kinds of benign disease. You know this. I mean, we have serous cancers, we have endometrioid cancers, but we also have germ cell cancers, gonadal stromal cell cancers, and what we just heard in the previous lecture, even within cancers, within one type, you have different behaviors, you have different types of tumors. Not all serous tumors behave in the same way and will produce the same tumor markers. And the same, of course, can be said for the benign masses. You can have an abscess which will behave completely different than a dermoid cyst. Besides that, also one of the problems is when we are looking for, in many of the studies that try to look for biomarkers, they include a lot of stage 1 tumors and healthy patients. And it's something that annoys me a lot, actually, when I read a lot of these papers. When you try to look for biomarkers for diagnosis, then you don't have to include healthy patients. When you want to do studies for screening, then you need to include a lot of healthy patients. If you want to make a difference between benign disease and malignant disease, then only use benign disease and malignant disease, because you make your results better when you also include these healthy patients who don't have any cyst at all, who don't have any immune response, who don't have any reaction of their body, who don't have any tumor that produce any proteins. We know that early stage disease also, in most of the, well, it almost doesn't produce any tumor markers, at least tumor markers that we know. And these are the tumor markers that we use now in the clinic, CA125 and HE4. And what you see is that the performance for stage 1 and 2 tumors is much less than for stage 3 and 4 tumors. This is no secret. Another thing is that many of the markers that have been found with proteomics are actually cancer-related or related to the reaction of the body to the cancer and not ovarian cancer related. So what the problem is that there are a lot of proteins in serum. So the differences that we find sometimes are just caused by the fact that there is a tumor. And these reactions might be the same when you have an infection or an inflammation or any other disease like heart disease. And this is a list of proteins that have been used, and this is not a complete list. This list is actually about 5 years old, so I have to double the amount of proteins. What you see is that you see a lot of interleukins. You see, of course, CA125. You see a lot of markers that also go up when you have an ovarian cancer, but are not necessarily linked to ovarian cancer. For example, CA15.3 is actually for breast cancer. But when you will look at it in every ovarian cancer patient, you will find a lot of ovarian cancer patients who also have raised CA15.3. And most of the discovery studies actually found acute phase reactants as possible markers. For example, CRP. Now, I never knew that CRP was an ovarian cancer tumor marker, but some people, some people dare to say that it's a possible marker. The same can be said for transthyretin, which is actually pre-albumin. And when you look closely, also albumin is in the list. These are all just proteins that go up and down when something is going on in the body. And then there are also the analytical and pre-analytical shortcomings and inappropriate statistical analyses. And I'm not going to go into that because that's going to, I can go on for that for some time. But what you have to know is that the result that you get from a sample, that you immediately freeze when you take it from a patient, or you have it on your table for about 5 or 6 hours, and then you analyze it. The difference that you find in your sample is probably going to be because of the time that you let the sample on your table at room temperature, because proteins tend to degrade when they're at room temperature. Not all proteins, but some of them do. I promised you that I was going to talk about OVA1, and this is because this is the only test which was discovered by proteomics that has made it to the market. It's commercialized in the United States. It all started with a study in 2004 by Zhang and co-workers. It was a study of 503 patients, and they identified 3 proteins, apolipoprotein A1 that went down, transthyretin or pre-albumin that went down, and inter-alpha-trypsin inhibitor H4 that went up when the patient had ovarian cancer. And this was a discovery study, and when they combined it with the CA125, they had an improved performance. Subsequently, there was another study of 635 patients, so these are big studies. And they looked at the same proteins, the 3 markers from the previous study, together with CA125, and they added another 4 possible markers: beta-2 microglobulin, transferrin, hepcidin, and connective tissue activating protein 3. Of 4 of these newly discovered proteins, they had a quantitative immunoassay. And together with CA125, they developed the OVA1 test. And this is very smart because you cannot patent these markers because these are just basic proteins. But they, of course, they patented the OVACalc software that you need to have to analyze your sample. This OVA1 test was cleared by the FDA in September 2009. And since September 2009, you can buy this, this test in the United States. They validated the OVA1 test in a multi-center trial, 27 clinical trial sites in the United States. So again, a big study. And they looked at benign versus malignant, and they were very happy with the results because they had a sensitivity of 91%. And in the premenopausal patients and in postmenopausal patients, they had a sensitivity of 95%. And they state that this is a very good result because when you have such a high sensitivity, you will almost not miss any ovarian cancer patients. But the second column is the specificity. And you have a specificity of 43% in premenopausal patients and 26% in postmenopausal patients. So you will have a lot of false positive results. And these are the results of CA125. And this is more balanced because they use the cutoff of 35 that we know, with a sensitivity of 77% and a specificity of 73%. This is the ROC curve. And what you see, the black dot and the gray dot is in the premenopausal and postmenopausal patients. And what you see is that it shows a cutoff, which is very much to the right side. So you have a very high sensitivity, but a very low specificity. What they didn't do is plot the result of CA125 on the same curve. That's what I'm going to do. And that's where CA125 is. So probably the curve of CA125 is absolutely the same as the combination of the 4 new markers together with CA125. The only difference is that CA125 is much cheaper because there's no patent anymore. So why would you buy an expensive test? And why not just, if you want to use it, why not just use CA125? And if you really want to, you can also put the cutoff very much to the right side, and then you will have a very high sensitivity and a very low specificity, the same as the over-1 test. So to me, and I looked at all the literature again, I did the same talk 2 years ago. There are no new data since over the last 2 years. I think the excitement was very high in the first few years after the Lancet paper, but up to now, the results are disappointing. So in 2006, in the beginning of my PhD, I gave a lecture in London, and I said, coming closer, but not there yet. I'm sorry to say I lied. Not there yet. So the take-home message. Are there any new markers based on proteomics for ovarian cancer? Yes. And the same conclusion. Are there any new useful markers based on proteomics for ovarian cancer? No. Thank you.
Okay, well, thank you for that uplifting message, Toon. No, it's interesting because we were in the States recently and they were very keen to use over-1, that's for sure. And they saw it as a, if you look at the difference between the States and the United Kingdom, if someone has symptoms of ovarian cancer, the protocol is they get a CA125 test in primary care, which is like a gatekeeper to getting an ultrasound scan, which I think is insane.
Yeah.
I think anyone thinks it's insane apart from people who do nice guidelines. In the States, they take the view that they should be using over-1, which probably makes more sense because well, you could adjust the cutoffs for CA125, but at least it's more sensitive. So in premenopausal women, you might, for example, get rid of a few by just saying, well, you're just going to refer maybe half of them or 40 or 50% of them for secondary care assessment. So that might be where you have some utility for something like over-1. That wouldn't be too stupid, and certainly no more stupid than what we're doing in the United Kingdom.
That's true. No, but I think if you want to have the same sensitivity, why not just you can choose a lower cutoff for CA125, which is much cheaper also.
Well, yeah, I would agree. Any other questions on the on biomarkers? Been a long day, I think. I think they've nothing more to say. Okay, Toon, many thanks indeed. Now we were going to have. What do you want to do, Dirk? I think we should finish. Okay, so we were going to have a discussion. I was going to put enormous pressure on Dirk to give me the way forward in terms of combining UKC tox data and IOTA data and talking about longitudinal data analysis. I thought we could have a discussion about that, but I think we're going to finish at that point. Is that what you'd like to do? So I'd like to thank all of the speakers today. We've had some great talks. We had new data, which has been exciting. We've had some depression from Toon, obviously. And I'd like to thank all of you who stuck it out to the end of the day. I think it's been a very good day. Thank you very much. And we look forward to seeing you tomorrow. And I also, of course, it's up there. I don't have that day. There's the welcome reception in the foyer, which has been offered by Roche. And apparently the speakers are having dinner after drinks. So thank you all very much. It's here. Right.